Well, we have a really important topic tonight, and it is something that we've never done here at HMRI before, which is to highlight mental health challenges. And before I get into a little bit more about that, I want to set the stage for you and talk about a few statistics and really set the playing field for tonight's conversation. So, the growing mental health crisis among the youth in the United States is accelerating at a very alarming rate. And in 2021, the U.S. Surgeon General declared a national state of emergency in child and adolescent mental health. So to emphasize the significance of this declaration, let me tell you some other public health threats that have been reserved for that declaration. Smoking was declared in 1964 as a public health threat. AIDS was declared in 1986 as a public health threat. And then in 2001, obesity was declared a public health threat. So this is reserved for things that are identified as a major crisis that we are on the verge of. To add to that, let me just talk about some statistics. The CDC has been polling high school students every 2 years since 2011, and the data that really led to this declaration of a public health emergency was what shaped this declaration. 42% of high school students experience persistent feelings of sadness or hopelessness, and that's up from 28% in 2011, so almost doubling. And 22% said that they were seriously considering attempting suicide. Today, suicide among youth and young adults ages 10 to 24 account for 15% of all suicides, an increase of 52.2% in the last 24 years. And youth who identified as sexual minorities, LGBTQ plus youth, had a 5-fold higher rate of attempting suicide. Several of the stressors that have influenced these trends include the pandemic has triggered fear, academic disruption, isolation from social distancing, and this was compounded by stressors that we also have rarely discussed. In the United States, more than 200,000 children grappled with grief over the loss of a parent or a caregiver. Among high school students, 29% had a parent or primary caregiver who lost their job. 55% were emotionally abused and 11% were physically abused. These are all data that came out of that survey. The concerns that teens had before the pandemic are now amplified today. These include social media use, online bullying, mass violence, natural disasters, climate change, and let's not forget political polarization, including the tone of the discourse that influences rights based on how a person identifies. And it's not just the sexual minorities, it's race, gender, religion, and sexual orientation. This adversely affects adolescents during a very critical time of self-identity, self-discovery, and how they develop their identity into the future. Some youth also suffer from mild or moderate anxiety and depression, and others have debilitating, serious mental illnesses. So those include psychotic disorders such as schizophrenia and bipolar disorder, severe mood and anxiety disorders, depression, and post-traumatic stress disorder. And then females, LGBTQ plus youth, and those who have experienced racism are more likely to suffer from poor mental health. Millions of children are impacted by structural factors like poverty, food insecurity, being unhoused, and all of these underlie health challenges as well. So you're probably sitting here tonight because you know someone who's a young person and you care about them and they may experience their own difficulties. They're more than just a statistic. They are your children, your students, your clients, your grandchildren, friends, and neighbors. And you witness their very real struggles with mental health every day. So tonight we have this very incredible panel of mental health experts that we'd like to offer you some insights, some resources, and hopefully some hope. So HMRI is on a quest to understand something that we've not studied in the past. And when Dr. Vasudevan came here, it became a new area of research. It is the biological basis of mental illness. And this research is promising for future therapies, possibly even cures for neuropsychiatric diseases like anxiety, depression, and schizophrenia. So I'm going to start there at this end of the panel and introduce Dr. Anju Vasudevan. She leads this groundbreaking research by studying angiogenesis in brain development. She's an associate professor and chairs our neurosciences area, overseeing basic and translational neuroscience. Before joining HMRI, she was a faculty member in the departments of neurology and psychiatry at Harvard Medical School, and she established the Angiogenesis and Brain Development Laboratory at McLean Hospital in 2011, and then moved it to HMRI in 2020. And the other panelists that are joining us tonight have dedicated their careers to specializing in adolescent mental health, working in the community with youth and helping them overcome present mental health hurdles. So I'll start with Dr. Cameo Stanek. She's seated next to Anju, and she's a licensed clinical psychologist and vice president of training and implementation practice at Sycamores. She also leads the Hathaway Center for Excellence, Sycamore's Training and Research Institute, and Dr. Stanek holds an appointment in clinical assistant as a clinical assistant professor in the Department of Psychology at UCLA. Casey Meinster is a licensed marriage and family therapist. She serves as the division chief of campus-based services at Hillsides Residential, partial hospitalization, and intensive outpatient program, as well as the short-term residential therapeutic program and Office of Refugee Resettlement and Shelter Program at Hillsides. And then finally, we have Dr. Amy West, is a professor of clinical pediatrics and associate training director for psychology in the Division of General Pediatrics and the director of the Children's Hospital of LA Child Clinical and Pediatric Psychology Internship. In addition, Dr. West holds a secondary appointment as a professor in the Department of Psychology at USC and a faculty member of the USC Interdisciplinary Center for the Changing Family. We have a fantastic panel, all of them dedicated to digging deeper and understanding this really critical issue. So I'm very much looking forward to addressing questions with all of you. So thank you all for being here. So to start the discussion, I'd like to ask each of you, and we'll start with Dr. Vasudevan and work our way this way, to each of you address this first question. What I'd like to ask you is, what are the greatest mental health challenges for children and adolescents from your vantage point?
Sure, Julia, that's a great question. I can answer it from a research perspective. I think one of the major challenges for mental illness is not having specificity about it. Like, for instance, when did this disease originate? Did this disease originate during the prenatal period or during the postnatal period? Not being able to specify a time frame is a big issue in the field. Again, we don't know which cell type in the brain is affected. Usually when children or adolescents go to a doctor, it's very difficult to predict which cell type in the brain is affected, which brain area is affected. There's so much that we don't know. It's about looking at the symptoms and providing medications. And so sometimes clinicians use what we call a shotgun approach. There are medications that fire a lot of bullets and affect multiple neurotransmitter systems in the brain at once, and it causes downstream effects. There are sometimes it works and sometimes it doesn't work, and these diseases are never cured. It's about finding a way to adapt to the disease and coping with it. It's more of developing a coping strategy, and the biggest problem is not having a personalized approach to treat specific mental illnesses. So is this really the depression, or does it change into schizophrenia over time? Now, having that overlap in symptoms is also a big issue. So I think that is one of the major challenges in psychiatry, the issue of having a personalized treatment for each child, and to find it as soon as we can. The earlier, the better. That specificity is not there in the cell type in the brain that is affected. And that's the biggest problem that we have in this century.
Yeah, I think from my vantage point, the things that I see, I'm going to go broad but get specific, is pressure. I think that young people are pressured. There's so much pressure to achieve. There's pressure to adjust after a pandemic. There's pressure. The childhood and adolescence is such an experimental time, and yet it's a public spectacle now like we have never experienced, with social media and just everything being out everywhere. No mistakes can be made because it lives forever. And the pressure that goes along with that, I think it results in some of the higher acuity that we're seeing in the field at this point. So there are these, specific areas that it's coming from, but I think just across the board, that's something that I have seen among the youth that we work with.
Yeah, similar to Cameo's experience, for me in working with the high acuity children and adolescents, I think it's social media and access to information, and for a few different reasons. Part of it is just the attention to the screen and the screen time and what that takes away from in terms of social interaction and life in other ways. So I think that's part of it. Also, it's just access to information that our youth might not generally have. So you have youth who have family or home life challenges, our own community challenges, and now they're also shouldering the world's challenges because there's so much information to wars in other countries and to different challenges that they might not normally see images of every day. And then also, I think just with the dopamine overload, there's a lot of youth who count likes, count views, check how many friends they have, compare how many friends and their connections are, and that's kind of a unique thing to happen for a young mind. So I think that is also, even though it's maybe more positive in terms of how they're interacting with social media, I think also has some challenges because they're constantly seeking the approval, the access, the visibility, and it's a little unnatural. So I think that leads to the pressure she's talking about. There's a lot of self-esteem challenges. I think it really impacts their mood and their impression of themselves and their world around them.
So I can speak kind of as a clinical researcher. So my research is all focused on kind of better understanding the development of mood and anxiety in kids, and then studying how we best and most effectively treat it and how we optimize, treatment based on more precision medicine and personalized kind of understanding of mental illness. I think the biggest mental health challenges facing our youth today are anxiety and depression, and the incredibly mounting rates of anxiety and depression. And the pandemic certainly exacerbated it, but it did not start with the pandemic. We had a pediatric mental health crisis prior to the pandemic. Our rates, if you look at rates of anxiety, rates of depression, rates of suicide, they've been exponentially growing since before the pandemic. So this is not a new issue that was brought on by the pandemic. The pandemic certainly exacerbated it, and I think made it visible, in ways that it hadn't been to people kind of outside of the field of mental health. But I think, anxiety and depression is I think, what is afflicting our youth. That is a problem, but I think it's not enough just to say, that's the problem. I think we need to look deeper. Why are our kids so much more anxious and depressed? What are we doing? How are we raising our kids as parents, as society, as an educational system, as a political system, in ways that are making our kids so anxious and depressed? I think we're still uncovering the answers to that question. I mean, I think a lot of it has to do with isolation and loneliness. Adolescents these days, despite, these incredible ways to connect over social media are more lonely and more isolated and more disconnected than they've ever been. And, you know, I think to Casey's point, a lot of that has to do with social media. I mean, we're really seeing right now the first generation of kids that have been raised entirely in a virtual space. I mean, our kids these days are not growing up like we did in real life, you know, going outside and playing till dark and coming and making up games and exercising creativity. They're growing up on a screen, sitting in their room by themselves, scrolling, you know, and doing social comparison. And it's just, and seeing images that their brains are way too young and not well equipped to process. And so I think the burden that the way that we're raising kids in our society now places on them is too much. Their systems are not built for it at the age that they're at. They can't process this information. They can't process the emotion. They can't adapt and develop in a healthy way without the connections that they don't have because of the, you know, because of the way that we're raising them. I also think that the way that we parent and the way that it is very different now in this kind of last couple generations of adolescents has been very kind of what we call over-parented. I'm sure you may have heard the term helicopter parenting, but you know, kids are over supervised these days, and there's reason for it, right? Like I'm a parent of young kids. Like the world seems like a scary place, and it's hard to send your kids out into it without protections. But you know, actually, when kids are over-parented and everything they do is supervised and there's no free play anymore and kids don't wander off and play by themselves, they're constantly supervised, they're just shuttled from structured activity to structured activity. And what research tells us that does is actually raise a generation of kids who aren't really competent. They don't know how to be in the world and make decisions for themselves and deal with adversity and exercise decision making, you know, in ways that are really important for development. So I think there's a lot of different converging factors that have kind of evolved over the last couple of decades, both in terms of shifts in kind of society and exposure and social media and parenting that unfortunately are creating a kind of, you know, cohorts and generation of kids who are feeling very sad and anxious.
Well, that's a good segue to my first question that's actually for you, Amy, and it's to tell us a little bit about the role of social determinants and what they play among distressed youth and how that's being addressed.
Yeah, so I think this is really interesting. I mean, the field of psychology and psychiatry traditionally has focused far more on individual level factors, right, and biological bases, which is hugely important to Anju's point. Like, we really need to know more about what is actually causing, or you know, at least creating predispositions for particular, you know, illnesses in our brains and our bodies. But I think, you know, unfortunately, the field has almost been like solely focused on that area to the detriment of better understanding the incredible influence that social factors and environmental factors have. And we're actually learning that social and environmental factors have a way bigger influence on the development and manifestation and course of mental illness than biological or genetic factors do. In some cases, not all cases, but in some cases. And so it's exciting, and I'm glad the field is going there because I think that's the needed direction. But you know, it's still new. I think we're still learning a lot about the role that these more kind of environmental and structural factors play. But I think you know, social determinants of health is this buzzword. It's you know, it's kind of everybody is wanting to study it, and the idea, you know, is that you know, we come into this world obviously with biology and perhaps genetic predispositions for our cells to operate and fire in certain ways, but what happens, like how that biology actualizes has to do with how it interacts with the environment. And that's the piece we don't understand as well. I mean, we have emerging research which tells us that factors like poverty, factors like access to resources, the experience of racism, discrimination, marginalization, structural racism, so being in a society where you're constantly invalidated or ostracized or marginalized, those things which we would consider external factors actually interact with us. They interact with our psychology, they interact with our biology and affect how our bodies actually manifest kind of our genetic, programming. And so, I think that that's what we're talking about when we talk about social determinants, are these kind of external, environmental, social influences which appear to have a much more powerful influence on development and on the experience of mental health problems than we ever kind of thought or believed previously.
Just to chime in to what Amy mentioned, this has actually brought in a new field, which is the epigenetic cause for mental illness, where there's a link between genes and the environment. And the environmental stresses just stay in the system and it passes down from generation to generation. So we are seeing a change in the way we define mental illness.
Yeah, it's really exciting. I mean, to really better understand that interaction.
So let's, Casey, I'm going to move to you and ask a question. If you could walk us through the process of symptoms, diagnosis, underlying cause, and treatment.
Yeah, so for the journey really starts with awareness and identification of the symptom onset. So traditionally, that can happen where a child or adolescent has some sort of change in their behavior, some shift in their mood, and that might be something that they themselves have identified and are seeking out help. But more often, you'll see school personnel, teachers, school counselors notice a shift. It can happen with your primary care provider when you go to see the doctor, noticing some shifts in maybe your weight or the appearance or some kind of behavior. It could happen with family members showing concern for symptoms that are starting to show up. So in some way, there will be awareness or identification that there might be some mental health issues that are present. And then a referral to treatment will happen. So when youth come into clinics like mine or any other clinic, it typically starts with an assessment. And what that looks like on the community level is typically a structured clinical interview where you're gathering information on where the symptoms started, what your development has looked like, what are any cultural considerations, any past experience with mental health, really sort of understanding and interviewing the child and adolescent, the family that has brought them in to get a better understanding on what their journey has been thus far. It can also include observations. We do a mental status exam, you do observations on how they're functioning. So all of this is to really inform a mental health diagnosis to see if they are meeting the criteria for a mental health diagnosis or multiple diagnoses. You also are looking at potentially what could be driving that. So there is attempts to look at underlying causes. Have they had exposure to a traumatic event, to stressful life circumstances? Has there been any substance use or medical diagnosis that could be impacting this? Is there, how long in their development has it come up? So there is attempts to understand what brought them there. And it all leads to coming to a conclusion on a mental health diagnosis. If we're lucky enough to have formal testing, that's obviously ideal. If they've had any exposure to psychological testing or school testing, that can be really valuable in that diagnosing process. But typically it comes from a clinical interview and observation. And then if the child or adolescent does have a diagnosis, that usually qualifies them for treatment. It oftentimes allows for reimbursement from a payer or health insurance. It also provides common language for providers to talk and to formulate a treatment plan. So all of that, the diagnosis really leads to informing the treatment. So once we have an idea on what mental health challenge we're working with, then that will inform the treatment plan and the treatment approach. So, oftentimes that's where some of the challenges can happen because, there's different treatment modalities out there. There's different levels of care. So some youth come in needing residential placement or intensive outpatient or perhaps routine outpatient. You have to have qualified and trained practitioners and clinicians. There's definitely a big shortage with mental health therapists right now, but ideally you would be able to match the diagnosis with a provider who is experienced and skilled to treat that diagnosis and monitor for its effectiveness. So it's there's a lot of areas where it could break down. We tend to see that from the onset of symptoms to starting treatment can sometimes be 10 years. By the time they're willing to seek out treatment, by the time they found a correct provider, received an accurate diagnosis, and been matched with a provider. So that's, everyone's journey is a little bit different, but traditionally that's kind of how you see from the onset of symptoms to receiving some type of treatment.
Wow. That's shocking, 10 years. So Cameo, I want to ask you a question about, could you say a little bit more about evidence-based practices in mental health therapy?
Mm-hmm. Yeah, so everything Casey just said makes, I imagine you're following the linear progression. And if you think about it from sort of a medical model, if you have a heart condition, especially if a particular heart condition, you would want to be matched with a cardiologist that treats heart conditions, and particularly the heart condition you have. Evidence-based practices in mental health, I think, is perhaps one of the most important innovations in the mental health industry, in the history of mental health, and it is the least utilized and the least demanded. And the good news, good and bad news situation here. Good news situation is that we have actually a wealth of cutting edge, top of the line treatment approaches, these evidence-based protocols or sort of manualized treatments for 90 to 95% of mental health diagnoses, conditions that most young people come to treatment for, whatever that route may be. But in terms of when they show up and the types of diagnoses and problem areas that they have, we have a huge wealth of available, very effective, efficient treatments for them. The majority of therapists that are practicing out in the community do not use them. And the general public often doesn't know about them or doesn't know what to demand, basically. Just by way of one example, for anxiety as a problem area, there's a number of anxiety disorders or kind of types of anxiety disorders. But for the sort of general problem area of anxiety, there are over 100 evidence-based practice protocols just for anxiety. The bulk of those, almost 90% of them, have one single therapeutic intervention. It's called exposure. It's a process. It's not like a quick thing, but it's exposure therapy. It's a therapeutic intervention that falls in 90% of those protocols. And it is one of the least underutilized practices in our whole field. And so again, good news, bad news. I think at the end of the day, in my opinion, there are three main reasons for this. One is that when you look back through the evolution of evidence-based practices across all different problem areas, there was such a drive for treatment developers to establish these EBPs as being effective according to a medical model. So the way that our medical treatments, our pharmaceutical treatments are tested in randomized controlled trials, and it's a very sort of pure sample of participants, and it has to be better than another treatment. And there's a lot of rigor that's involved, which is great. And what has come out of that is all of these amazing therapies and protocols that are highly effective. What seemed to be missing in the drive, perhaps, or the pressure to prove these mental health therapies at a time where a lot of people viewed mental health therapy as either not effective or it was all equal. Like all the therapies, all the treatments were kind of all the same. One pill for everything, and it's not really that good. So there was a lot of pressure to establish it. And what suffered from that, or perhaps this happened at the expense of PR, basically. PR for the general public, PR for providers to understand really what it takes to be able to deliver these treatments. That's perhaps reason number one. Another reason is funders, insurance companies, policymakers don't know about EBPs. They don't know what to ask for or demand. And as we all well know in mental health, this is an industry that's inextricably tied to politics and funding. So the funding doesn't necessarily always support the EBP, require the EBPs. And then third is there's not a lot of good examples of what accurate mental health therapy done in an evidence-based way even looks like. Media, movies, books, TV, until very recently, there are not a lot of good examples of what evidence-based treatment looks like. So as, a parent, somebody who's at their most vulnerable state, a young person coming in especially, no idea what's happening behind the therapy door. Could be anything. There's no WebMD for psychology, for mental health, right? So as a person who's maybe supporting someone who's suffering, we don't even know what to ask for a lot of the time, and we don't have good models of that. So the good news is that there's a ton of good stuff out there. It's just about finding those providers that are trained in it and being able to know what to demand ultimately.
So can you just define what does it mean to be evidence-based?
So generally speaking, there's a few different kind of definitions, but it's a combination of things. So one is a solid scientific foundation, which means that there have been multiple peer-reviewed, so they're being published in peer-reviewed journals where there's a treatment approach that has been compared to other treatment approaches, has also been compared to no treatment, but at the top of the line, it's compared to other already effective treatments, and that has been repeated. So back in middle school scientific method, we've got to form hypotheses, test them out, and then repeat them. So it's being established as something that's effective to bring down those symptoms that we're seeing, the suffering, the struggles, bring that down to at least a tolerable level or getting rid of it altogether. So there's a lot of monitoring that goes on with that, and that those treatments are being tested repeatedly by different teams so that there's not so much bias if I'm the treatment developer, of course I'm going to say this works, but there's multiple treatment developers looking at it. Plus, the clinical judgment of providers goes into developing and creating that evidence base as well. The training that a provider has that can help to individualize those practices, just like your cardiologist is going to adjust the dosage, right? And maybe combine it with exercise or something like that. So the clinical judgment is part of that. And then the individual needs of the client themselves, of the young person or the adult themselves, where there might need to be some individualization that happens. All that together is an evidence-based practice approach. Mm-hmm.
So, Amy, I want to come back to you for a minute and ask about the role of medication and how medication can be balanced with therapy or evidence-based practices.
Yeah, so I think, as this whole kind of field of evidence-based therapy was developing and lots of psychosocial interventions were being tested through rigorous trials, medication has also been going through a similar, process of these kind of, medications being discovered to target various neurotransmitters that were either conceptually or scientifically known to be involved in the expression of depression or anxiety. And in many ways, it's funny. I think there's often this perception that medications are somehow more sciencey or exact, or because they're medications. But in many ways, like with psychotropics, with psychiatric medications, we know just as little kind of about the true mechanisms. I mean, that's in psychotherapy, I feel like we have all these evidence-based interventions. We don't always understand exactly how they're working, right? And that's a lot of what I study, is trying to drill down into the either biological or psychological mechanisms that explain exactly what these treatments are doing. And the same way we have to do that for our psychotherapies, we kind of need to understand that for our medications too. And we don't always with psychotropics. I mean, we kind of have a sense of what they're doing with, selective serotonin reuptake inhibitors or dopamine agonists. But we don't always, understand exactly what they're doing in the body. But we do have, many classes of medications that have been shown through rigorous research to be effective in reducing symptoms. And so they are widely used. I think they're often, depending on the clinical presentation. So for like anxiety and depression, I think a lot of the trials have shown that medication and CBT, cognitive behavioral therapy, which is kind of the most evidence-based intervention for both anxiety and depression, are pretty equivalent, in terms of their effectiveness, and many times also work a little bit better when they're combined. But I think what we don't truly know yet, which is I think where the research needs to go, is like that's an average, right? That's like averaging across like huge populations of people being studied. I don't think we know for you or for you, like what would work and when, and I think there's probably individual characteristics, whether it's psychological characteristics or biological characteristics that we could use to determine who's going to respond better to medication, who's going to respond better to psychotherapy, or who might need both. So that's, I think, where we need to go as a research field. But they're both effective. They're both safe. I mean, that's the other kind of misunderstanding of medication. A lot of the medications that we use in kids, like SSRIs for anxiety or depression, are very well tolerated and very safe. And I think that's a concern a lot of parents have. But these are pretty benign medications. When you get into bipolar and psychosis and you're using antipsychotics, those medications do have a little bit more side effects. And, there's more that need to be, monitored and watched. But, medications are widely pretty well tolerated and acceptable, and can be good adjuncts to psychotherapy.
Great. Thank you. So, Anju, I want to come back to you. And now we've established some understanding of the challenges and the issues around therapy and treatment approaches. Talk to us about the biological basis of mental illness and what is happening in the developing brain, and perhaps if you can extrapolate to, an adult brain or almost adult brain that has gone through some of these changes that may happen to impact the rest of their life.
Yeah, if I were to summarize this in one word, I would say the key aspect of brain development is organization. It's a big thing. If you've been to an orthodontist with your kids, you'll see how they care about your teeth being very organized, right? There should be no crowding. There shouldn't be an overbite. Everything has to be in the right place. And that's the key aspect of brain development, because during prenatal brain development, there are many key events going on. New cells are being born. They have to migrate long distances to find their final destination. They have to say, okay, we have to go from the ventral part of the brain and form what's the dorsal part of the brain, and the neocortex, which is the top part of our cerebral hemisphere, is a very organized 6-layered structure. And cells need to find their way there. They need to say, okay, this is where I need to sit, and this is where I need to connect with the next cell. So it's a big time. There's so much stuff, so many key events going on during prenatal development, with a time that's the black box of life. We have no idea what's going on. We see that expectant mothers are happy, this 9 months that you have to wait until you get the baby in your hands. But there's so much going on during that time. And so there are environmental stresses also happening during this time that can affect your baby's well-being later on. So from what I've seen all through my studies on prenatal and postnatal development is how beautifully our brains are shaped up. And once these events happen, there's no going back. Whatever needs to happen during prenatal brain development needs to happen. And after birth, there's another set of events, which is the brain starts wiring up, connectivity starts forming. And that's exactly when the environmental stresses also hit, because as your brain is wiring up, you get hit by different environmental issues, and you're not coping. Your brain's not there to cope with it. So it's a big time, both during prenatal development and during postnatal development. And it's very important to take care of this time. And it's very important for the well-being of your child. It could be a genetic trigger, it could be an environmental trigger, or a mix of both.
Right, thank you. So I want to switch gears a little bit. And Casey, I want to ask you about outcomes. And when you look at adolescents that go through an evidence-based program or other kinds of programs. How important is early intervention, and what are the things that we need to be paying attention to looking at outcomes?
Yeah, I mean, ultimately and simply, it's symptom reduction and looking at the impairment that was being caused by the mental health symptoms. So if you think about someone who has, let's say, depression or anxiety, and maybe they've lost interest in things that they used to do all the time, their school is suffering, they might be having a lot of truancy or at risk of school expulsion or being held back a grade. Or you might have someone who's avoiding places and leaving their home. They won't be away from their family. So there's some kind of impairment in the school setting, with their friend group, with their parents, that has led them to come to treatment in the first place. So the idea would be, with the outcome of the treatment would be reduction in symptoms, that there's some type of quality of life that has been restored. They're back into there's less family conflict, there's improved academic functioning or school attendance. So the outcomes really vary depending on what the needs are. So generally speaking, in treatment, you would have some idea of what the baseline need was, what your targets were, and that ideally at the end of treatment, you would see a reduction in symptoms. I think one of the differences with using evidence-based practice versus just traditional treatment or whatever else is being done behind the therapy door is you might see temporary relief. There might be some sort of hope that has been instilled and they might be feeling better. But what we would want to see is sustained gains, that they've received treatment that has helped build skills and resiliency, built awareness, and hopefully coping that will persist when the next challenge, the next environmental stressor comes, so that they're not being hospitalized again, they're not falling back into the old patterns. And generally, when you see targeted evidence-based practice, you see longer-term outcomes. And so in terms of early intervention, I think it's kind of obvious when you think about how important that would be. Because if you think of traditional development, so if you think of a child going into adolescence and all the things that are happening for them, they're learning frustration tolerance, they're learning about their own autonomy, they're learning how to navigate the world. And when you have mental health challenges, that disrupts that process. So while you're working on the mental health challenges, you're losing valuable developmental milestones that then can become problematic down the line. Oftentimes in programs like mine, when we have 6 to 12-year-olds, we're often like, we got to help before they get to adolescence, because imagine all that comes during adolescence. So generally, the earlier you can kind of intervene, build skills and resiliency, there'll be some protective factors. So early intervention is always ideal. Obviously, sometimes you don't get the luxury of that, but even, we're hearing is prenatal, like it could go as far back as to when you're, at that stage of life. But generally with children and adolescents, you want to get to them before they get to adulthood, which then can be much more challenging to intervene.
So I'm gonna, time is really tight, and I feel like we've just barely scratched the surface. So Cameo, I want to ask you a question. I believe it was Casey that mentioned the shortage of therapists. And in general, there's a shortage of mental health services in the United States. So what's the best thing that someone in our audience who's listening tonight could do if they know about a child who needs some mental health support?
Call Sycamores or Hillsides or CHLA, first of all. Yeah, I think that, one good place to start is some of the kind of big, highly respected professional organizations like the American Academy of Pediatrics, NAMI, which is the National Alliance for Mental Illness, National Council for Wellbeing, National OCD Foundation, just thinking about anxiety. There are these big organizations that are, have good reputations, that are going to be promoting and including provider networks and ways to connect with or identify providers in some cases who are more aligned with those evidence-based practices, like we were mentioning. If you have insurance, if you're lucky to have insurance, you can start with insurance. It's tricky. I don't know if anybody has recently tried to find a therapist through their insurance. You get a big long list. You call a lot of people. I also see clients privately in 4 years, I would say. I haven't had a single client, family call me to say, anything less than I've called 20 providers and you're the first person that's called me back. So it's rough out there right now, and going through your insurance can be really tricky. But if you know someone, if you know a friend or a colleague, take our business cards. A lot of folks who are in the industry, even if they can't necessarily serve the person that you're concerned about, they might know someone, they might have access to provider networks that they can help, to find someone. There are a lot of school resources now more than ever. One silver lining to the pandemic is that schools do have more resources than usual. Again, to Amy's point earlier, there was already an issue well before the pandemic. But there has been funding that has come into schools across the country that has helped to provide some more resources than in the past. Even online resources, if you've got a young person that's maybe hesitant or not sure about wanting to talk to somebody or what have you. LAUSD has this big Bright Line service that they've launched, which is all virtual, just to be able to start to get accurate information, kind of where it needs to go, help to open their minds. And then I think other than that, something a lot sort of more basic is to think about how you're talking about mental health, how you're talking about your own coping, being a model for young people. Ask questions, ask them directly, wait patiently, but be persistent, and keep talking. Keep that conversation kind of above board. Again, I think a silver lining of the pandemic is that mental health is being discussed more than ever before, which is fantastic. I know there's not enough providers to support that, but at least it's being discussed. So there's got to be something good that comes from that, and just be persistent in reaching out.
So I want to ask one more question, and I want to ask this of Anju, and then I'd like to open it up for questions from the audience. So Anju, tell us about some of the groundbreaking research in mental illness that will benefit teens and parents.
Well, I think we're at a good place now. A couple of centuries ago, physicians would drill holes into your skull to let the evil spirits out because it was considered to be supernatural. There's a lot of groundbreaking research going on in many labs across the world. It's a collective effort, and it's definitely, there's hope on the horizon. I want to tell you that the 21st century is probably going to be the most transformative for psychiatry. In terms of the genomics aspects, there are labs that are really tapping into specific loci within the genome, and they can associate it with either PTSD or schizophrenia or depression. So that's a big change in terms of the genetic aspects of the disease. There are papers that are being published in Nature Genetics even now, right recently in April as well, April 2024. So the genetic aspect is a big deal. There are interventions going on like non-invasive brain stimulation methods for anxiety and depression. So that's a very cool aspect for treatment. There are AI-based approaches for recognizing postpartum depression in mothers so that environmental stresses don't affect a child's well-being. And then most importantly, I think one of the most significant aspects of this century is stem cell-based approaches for psychiatric diseases. We've come a long way because today we can take blood from patients, bring it back to the lab, reprogram those into pluripotent stem cells, and then differentiate those into the brain cell that we want to. So we can transform cells from adults and go back into a window of time. It could be even prenatal brain development, and find out what went wrong. And if we identify which brain cell type is affected, we can find a way to specifically treat it. And that's an approach that we use in my lab. Our lab, the way we've contributed to this research is that my lab was the first to show show a very specialized population of endothelial cells within the prenatal brain that is that can directly cause mental illness. So we shifted the field. Instead of looking at brain cells all the time, we started looking at it from a vascular perspective and from a neurovascular perspective. What we found is that this vascular cell population is, if it's imbalanced or if it's abnormal, then it affects downstream neuronal development. And it can cause a wide range of behavioral abnormalities. By trying to fix this vascular abnormality early on in preclinical models, we were able to rescue the abnormal behaviors. So we're at a point now where we are generating human embryonic forebrain endothelial cells. And we've tried to use it for cell therapy, and it's been very successful in a preclinical model of schizophrenia, anxiety, and depression. We're also tapping into this population to see if it's abnormal in patients from, let's say, with schizophrenia versus depression or any other mental illness. The diversity is huge. We have a huge control over this, which means that we can tailor a specific therapy. If the defect is not in the neurons, then why are we treating the patient with a drug that's not going to affect them? It's not going to cause them any change. It's a partial effect. It's causing a partial therapy. So we're trying to find a very specialized way to treat mental illness by using a neurovascular perspective and bringing stem cell technology into our lab. And finally, one of my long-term goals is to be able to diagnose between psychiatric disorders. How do we differentiate between schizophrenia versus depression early on? If blood is the pathway in, we can tap into blood samples from patients and create a blood test that's very specific for schizophrenia versus depression. And that's where we've started a collaboration with Sycamores and CHLA. We're hoping to get blood samples from individuals. It's a community effort. We really need people to know the significance of our research, contribute blood samples for the work that we're trying to do in the lab, and to eventually build a change, create a change that will reverberate within the California community and beyond.
Great, thank you. Well, this has been really interesting, and I wish we had a lot more time, but we're getting close to the end, and I wanted us to have a little bit of time for some questions. So, Paul, you want to field questions?
Sure, I'll run around.
Hello, this is super fascinating and interesting, especially for me as an educator. And you guys mentioned that early intervention is ideal, especially before adolescence and adulthood. And what do you think schools could be doing? Like, what effective programming can schools implement to help students develop like coping skills if they're having mental health issues currently, or if those develop in the future?
Happy to start with this one. I have lots of thoughts about this because I've actually been working with LAUSD to help train their school counselors and school psychologists about exposure-based models for treating anxiety, because those are so important and I think misunderstood. But there's two things I would say. I mean, the first is that I think part of what's not working is that mental health and mental health promotion isn't infused in all the places it needs to be, right? We're relying on our like specialty tertiary care mental health clinicians to treat, this huge population, which there's just no capacity, and there never is going to be. There's never going to be enough psychologists and psychiatrists and LMFTs and social workers to treat this problem. So I think I would love to see schools not be just about academic education, right? And start to treat emotional health and behavioral health as important to target for education as learning math and science and reading. I think that, we've got to start bringing mental health education and promotion into the Indigenous everyday context where our kids learn and play and socialize. So that's one thing I'd say. And it's hard because that's not the way our educational system is structured. And that's not what administrations, they may care about it, but everybody's like facing these pressures. It's all about testing and academics. And but the other thing I'd say is that I think that there's really exciting opportunities for school-based personnel and educators to partner with mental health clinicians. I mean, it's been really exciting for me to partake in this partnership with LAUSD to train their teachers and counselors about, how do they deal with anxiety in the classroom? Because frankly, only about less than half the kids with anxiety will ever get a mental health referral, will ever make it to see a clinician. So who's going to see them? It's the teachers, it's the school personnel. Like, this is where, we need to equip them with the knowledge and the skills so that they can intervene in the classroom and in the school setting. So I think there should be, or could be, a lot more partnership between places like CHLA and Sycamores and Hillside's, organizations that are mental health specialists and school environments to start creating some of that crosstalk and education and training opportunities.
I just want to add that I'm familiar with a program that's now statewide in California, that primary care healthcare providers are also going through this kinds of training in the community health clinics, because that's the first place where a lot of people will go for treatment for something. And if a primary care, like a nurse practitioner or a physician, are trained on how to screen for basic mental health issues, then that could be the point where they get a referral. And I'm so happy to see some of our first responders here are from our sheriff's department, because that's also a place where oftentimes the manifestation of a mental health issue ends up in the hands of a police person. So, yeah.
We also, just so you know, resource, again, I promised I wasn't all doom and gloom. My agency, we have a couple of federal grants from the Substance Abuse and Mental Health Services Administration, and one of them is to support youth mental health first aid and mental health first aid training, which is for anyone, anybody. You don't have to have any kind of mental health background, and it's training that we can provide free to the public. We're actually targeting first responders and educators and folks, in the community. We're not the only place that provides it, but it's a really great training that is excellent to get just a understanding of mental health diagnoses, reducing stigma, some intervention information to get people to referral, as well as we also do a suicide prevention training that's called Assist, that is also for the community. So the more that folks in school buildings can partake in that kind of learning the baseline knowledge, and hopefully pushing that further and further back into educator training programs in school, in their graduate programs, in undergrad, as well, so that they're not having to catch up with all these things that we hope that they will implement. So, yeah.
It was an honor to hear the five of you. What a terrific panel. I was discouraged when I heard Dr. Bradshaw's statistics at the start about all the different mental health challenges going up statistically. What can we do? Certainly supporting HMRI, absolutely, but what can we do as individuals to help with this? I'm just sitting here saying, what can we do to help this youth mental health increasing issues and all sorts of problems?
I mean, I think from my vantage point, I think just enhanced awareness and screening, because like we're saying, mental health professionals can't do it alone. And so there's still a pretty big stigma around mental health that prevents families, maybe it's cultural, maybe it's something else that prevents them from seeking out care. So I think the more that we are aware of mental health, and one of the programs Cameo is talking about is sort of similar to like CPR and first aid. If you think about how many of us may have received training in that, even if we're not a doctor, and so that if you are faced with that in the community, you can assist. So it's similar to that, I think, with mental health, where you can identify signs and symptoms, you can be a trusted adult, you can provide resources and awareness. That's really, I think, where we'll eventually get ahead of some of this, is just expanding the pool of helpers and first responders who are aware of the mental health symptoms. So that's one piece of it. I think it was mentioned earlier, some PR for mental health too. And the stigma is a really big piece of it, just being being able to feel comfortable seeking out care, it being championed, it being a priority, maybe over something like academics and testing. You know, it should be just equal to some of these other concerns, just like you would respond if you had the flu or COVID. It should be no different if you're suffering from depression or anxiety, that same level of approach and intervention.
The other thing I would just add to that is just to say, like, serve as an advocate in whatever setting you're in. You know, I mean, I'm sure there's people in all sorts of different professional contexts, but if your organization, you know, funds certain things or, you know, does any kind of policy advocate, but just whatever space you're in, which is all different spaces for all of us, like whatever you can do to try to elevate, you know, this as an important issue. Because I just think it hasn't been seen with the same level of gravity that like heart disease or cancer, but it's as big a killer, you know, especially of our young people. And so I just think, you know, any like whatever we can do in whatever settings that we're in to try to elevate this issue and communicate its importance, and the importance to, you know, to fund programs and to support providers and educators and, you know, people on the front lines, you know, is really important.
Yeah, I would like to add that, you know, if you could spread the word that we do mental health research at HMRI, then that would be very helpful, because it's definitely a new area that we've brought to HMRI. And stem cell work is very, very expensive.
Yeah. Final question.
So based on your clinical encounters, can you identify people who are particularly susceptible to drugs of abuse, who are pulling their own strings to cope and because we have increasingly open access to everything from cannabis, nicotine, opioids, hallucinogens, and society seems to be coping with that. But based on the Ozempic effect and some other things, it seems like some people are more susceptible than others. And can you figure out who need to be kept away from those things versus those who are reasonably able to have open access without abusing them?
Mm-hmm. Oh, yeah. Oh, go ahead.
Yeah. Oh, you could start.
Okay. I was just going to kind of go back to something Amy mentioned earlier about the question about social determinants of health. I'm sure that we know that there are certainly areas of research that can identify some sectors of the population or folks who have certain indicators in their genetic history, their environmental history, et cetera, that might make them more susceptible to addiction, for example. But I think also broadly speaking, so many drugs of abuse are a symptom of another problem. And so again, the earlier we can get to folks to intervene upon other mental health issues, there may be less likelihood to be then turning to drugs of addiction as a way to cope, or developing something that develops into an addiction, because those things do go hand in hand. So when folks are already vulnerable from lots of different reasons, in underserved communities where there's lots of violence and trauma, familial violence, the historical trauma that's passed down for certain groups through their generations, right, that already is putting, probably at a genetic level, putting folks at risk of being susceptible to whatever coping mechanism is available, and often the quickest ones are the unhealthiest ones. So it's just a thought that I had.
Yeah, I think this is a big issue. NIDA is addressing it completely to see what's going on, because the mechanisms in the brain change with substance abuse, and so targeting treatments for adolescents who have gone down this path is very difficult. It's just a new trigger, a new substrate. So understanding the biological basis of this substrate is NIDA's goal. I think it's important also to understand that there are withdrawal symptoms that come with it, which is a big issue. Setting goals, I think that a key aspect for adolescents is to learn to set goals, long-term goals, and to avoid substance abuse and other such triggers for mental illness. That's definitely the way to go about it.
Thank you so much for being here. Thank you, all of you.